Any changes made, we'll let you know. In just a second, we'll let you know. If you would like to review your test after class, feel free to come see me. You can do it today, you can do it Wednesday, whatever your preference is, but I'll be happy to review with you for anybody who would like to review. If you are in my clinical group and you want to wait for tomorrow, I'm happy to do it with you all tomorrow because we'll have time. So if you're in my clinical group and you just want to wait, we can take care of that tomorrow as well. So, as I said, I would like to talk about this, but I'm not going to. I want to hold myself back to talk about the test. I want to. Overall, it really looks pretty good as a whole. So, we'll talk more about it on Wednesday. And so whatever happens, shake it off, and it's okay. And I don't think anybody is to a point. Nobody in this class cannot pass this class. A lot of times by this time of the semester, we have students that we start to see are just they haven't passed any tests, and we can see they're just not going to make it. I don't see that with any one student in this whole class. There's not one student that cannot still pass this class, that hasn't passed tests and hasn't shown that they've done well. So in that way, you guys are a little bit different than a lot of classes, and in a good way. There's not one student here not capable of passing. So, if you're struggling, hang in there. Come see us. Let us try to help you a little bit. I know for some of you, this OB content is something that you struggle with a little bit. Okay? We'll help you. We'll try to help you get through it as best that we can. So, next Monday's quiz, is fetal monitoring, 25 questions, only covering these two chapters. So fetal monitoring, I don't want to say it's like a foreign language to you, but it's something that you've never had before, and it's something that you're going to have to take what you know and apply it to this content. So we've got a fetus that we can't see or touch, and they're being subjected to a stressor, and the stressor is labor. And so what we have to do is to figure out how to determine whether the fetus is under stress or not, and then what to do, whether it's significant enough that we need to do something about it. So that's what fetal monitoring is all about. It's mostly the whole idea about fetal monitoring is that we look at the fetus during labor. But it's also expanded now that we do have risk patients, and we do fetal monitoring for them as well. Fetal monitoring is for a third trimester pregnancy. You cannot do fetal monitoring and get accurate results before the third trimester. Can we put somebody on the monitor and maybe see the baby's heartbeat? Yes. Can we see if they're having contractions? Yes. But can we really determine fetal well-being before the third trimester? No. So it's really important to remember that if we're dealing with a 24-weeker, while we may be able to see the heart rate, we can't determine fetal well-being from these things that we're talking about. So this is a third trimester situation when we're doing fetal monitoring for fetal well-being. So keep that in mind, that before 28 weeks, it's just not really accurate. It gets a little bit more accurate as you approach 28 weeks, but certainly that is where we determine the cutoff. Also, I want to mention here, I put fetal assessment during labor concept reproduction, but after I thought about it, really, if we're thinking about the fetus, the concept is not so much reproduction, but what concepts, if we're talking about fetal monitoring, all the things that we know about how the baby's oxygen levels are, what concepts would we be referring to? Gas exchange is one of them, yes. What else?
Perfusion.
There are three. Who said perfusion?
Me.
Perfusion, very good. Perfusion. There's one more. What's the third one? What else do babies need in order to be healthy? Nutrition. Those are the three concepts that we associate with the fetus. They need gas exchange, perfusion, and nutrition. So really, that's what we're talking about. The nutrition comes from the glucose and things that they receive, but their growth is definitely affected by oxygen as well, and sometimes if they're not getting good oxygenation, they're also not getting good nutrition. So they do go hand in hand. Okay, electronic fetal monitoring is just a tool that helps us look at the fetal heart rate and look at fetal heart patterns on a monitor, and it prints it out on paper. This is what the paper looks like. This is actually a piece of fetal monitor strip. These papers last 8 hours in the machine, but this is what they look like. And I'll show you on the screen a little bit. You can look at them in more detail. You're welcome to come up and look at a piece of it if you want to. But it graphs out on this. This is kept as a permanent part of the patient's record. I don't know what they do with them now. They certainly store, but they used to do microfilm and then microfiche. I don't know if there's something to replace that with more modern. Lack of technology knowledge, but I'm sure there's a way that they store it. It's probably different than that now, but it is stored. When there's a lawsuit, that's the first thing they go to get. The monitor strip, because that's the proof in the pudding of what's going on with the baby. The nurse can write any notes that she wants, but that's the evidence right there. It was first used, fetal monitoring was first used in the 1970s, and the idea is that if we could monitor the baby more frequently, we could prevent diseases like, not diseases, but conditions such as cerebral palsy. Cerebral palsy occurs, you may know why cerebral palsy occurs. What's it caused by? It's caused by hypoxia. It's caused by fetal hypoxia. And there are two things that can happen as a result of fetal hypoxia. Either A, cerebral palsy, which spares the brain but causes spasticity of the muscles. So people with cerebral palsy, their brain is normal, they're intelligent, but they have spasticity of the muscles, difficulty speaking. If you've ever known somebody with cerebral palsy, they usually have a very different walk. Their legs are bent sometimes, and they have a lot of muscle spasticity. Or you can have normal physical function, but actual brain damage. Usually when you see brain damage from in utero hypoxia, it's one or the other. We use fetal monitoring now, I think probably too much, but we use it a lot. We use it all during labor, and we also, again, do it for our high-risk patients, like they'll come in once or twice a week in the third trimester for antepartum high-risk testing. Before we had that, we had, we could use a Doppler or something called a fetoscope, which is sort of like a magnified stethoscope, and you could hear the baby's heartbeat with that. And you could hear a rate at a certain time, but you could never identify a pattern because you couldn't see it on paper. How do we identify patterns? You have to see it and look at it. So if all you can do is hear it, you could never identify patterns. That's really where we benefit from being able to identify patterns of fetal heart rate issues. So first of all, a fact, labor is a stressor. That's a fact. If you think about contractions, so the uterus contracts like a muscle, squeezes in on the baby, right? When the muscle contracts very tightly, it constricts the vessels in that muscle, okay? So if you're constricting the uterine vessels when the muscle contracts, what effect is that going to have on fetal oxygenation? It'll diminish it, right? If there's less oxygen available to the baby during the contractions, then it just makes sense the baby's going to get less oxygen. So probably at about a peak of the contraction, if it's a really strong contraction of a patient in active labor, they're getting approximately, this is just the best guess we have, half or less of the available oxygen that they would have gotten. So during the peak of the contraction, their oxygen levels are cut at least in half. Now, if we have too many contractions too close together, that piles up over time, right? And so then that baby can become very stressed and very low on oxygen. So with labor being a stressor, let me just explain why. And that's why we monitor the baby very closely during labor. And especially for patients on Pitocin or any interventions that we've done, it's even more important that we keep an eye on the baby. So that's why frequent monitoring is a part of nursing care during labor. Nurses that work in labor and delivery become certified in fetal monitoring or advanced fetal monitoring and become very good at being able to figure out what's going on with the baby. We must maintain fetal oxygen supply during labor to prevent fetal compromise. There are things that we can do to help promote fetal oxygenation that we're going to talk about. Okay, so let's talk about things that can reduce fetal oxygenation. So I just talked a minute ago about contractions, right? The reduction in blood flow in eardrum space and placenta related to contractions. So the vasoconstriction from the uterus causes lack of blood flow in the baby. So that's one thing. Reduction of blood flow through maternal vessels as a result of hypertension and hypotension. Does it make sense to you that either one can cause reduced fetal oxygenation? Hypertension causes reduced oxygenation because of what? Vasoconstriction, which leads to what? What does hypertension and vasoconstriction lead to in the pregnant woman? Placenta what? Calcification, right? The placenta calcifies as a result of high blood pressure and subsequent vasoconstriction. Anything like that calcifies our placenta. Our placenta gets calcified over time as the patient's overdue. That's one way. But also as a result of hypertension and subsequent vasoconstriction. So is it possible that a patient who uses methamphetamine on a regular basis might have placental calcification? Does that make sense?
Yeah.
Absolutely. Yes. So that's hypertension. So our preeclamptic patients, could we expect our preeclamptic patients to maybe have some placental calcifications? Yes. Have you ever heard of a preeclamptic patient having a baby with IUGR, intrauterine growth restriction? Yes, because that placental calcification not only leads to low oxygen levels, but lower growth. And if oxygen's not getting through, nutrition is not either. So those babies are often small and have IUGR, intrauterine growth restriction. On the other hand, what's the problem with hypotension? Why does a patient with hypotension have poor fetal oxygenation? What happens when the mom's blood pressure is low? What's going on in the body that's affecting the oxygen levels?
Oxygen's not being moved.
Decreased cardiac output, right? If my mom's blood pressure is low, is her cardiac output reduced?
Yes.
Yes. If her cardiac output's reduced, is the amount of output that's going to the uterus going to be reduced? Uterine blood flow is reduced? Yes. If uterine blood flow is reduced, is placental perfusion reduced? Yes. Okay? So we have problems from both high blood pressure and low blood pressure. Either one causes a problem, right? Reduction of oxygen content in maternal blood as a result of hemorrhage or severe anemia. So my patient's blood pressure can be low for a variety of reasons. It could be because she just got an epidural and she's having a hypotensive episode from her epidural, right? Could be that. But it also could be that for some reason she has significant blood loss, subsequent anemia. And so anemia is just going to cause low cardiac output, right? Low blood pressure, low cardiac output, low placental perfusion. Alterations in fetal circulation with compression of umbilical cord. So we're going to talk about this today, but if the cord gets squeezed or compressed or basically, bent in half, what's going to happen to the baby's blood flow? It's going to be reduced or stopped, right? The cord can cause a huge problem. Cords in utero, we talked about the patient whose water broke last week and she has a cord prolapse. If that cord gets smashed between the head and kind of falls out and gets smashed, falls out the vagina rather and gets smashed, we talked about how that's going to affect fetal blood flow. So anything that causes the cord to be compressed will stop the blood flow to the baby or reduce it, depending on how much compression that there is. So all these are possible causes of reduction in blood flow. So as we go through these, they should make sense to you. You might not have them all down and memorized yet, but it should make what we're saying should make sense. We've talked about it enough that it should, kind of flow that you understand it at least. Okay, so monitoring techniques. So again, back in the old days, we used the old fetoscope. It looks like this, and you put your head on it. I don't know how we ever used those things. Looking back, I'm like, did we ever hear anything, or were we imagining things? But a Doppler certainly is a much better thing to what we have now. If you go to a physician's office on a regular OB appointment, you'll see them just listen to the baby's heartbeat quickly with the Doppler. They just want to know, is the baby there? Is there a heartbeat? Is everything okay in terms of the baby being still with us? But if we want to know about more detailed information, we've got to have monitoring on this paper so we can look at it and see, is there a pattern going on? Also, how do we tell if the patient's having contractions unless we can put our hands in our belly sometimes and palpate mom's contractions, but other than that, the only way we know is to see them on the monitor strip. So listening with the fetoscope or a Doppler doesn't give us any information about contractions. This is just, again, a picture of a midwife using a fetoscope to listen to the baby's heartbeat. Okay, so placement of the fetal monitor. There are two. One's for the heartbeat, one's for contraction. If you look right over here, this top one up here, that's the TOCO. TOCO means contraction. The TOCO is placed on the fundus or top of the uterus, up here at the top. If you put your hands on the mom's abdomen, feel where the top of the uterus starts to roll back, you feel the tip top of it, that's where you place that TOCO, because that's where you can my hands on a pregnant mom's belly, I can feel, and if she has a contraction, it will literally tighten under my hand. You can feel that muscle tighten up like a hard rock, almost. Now, the fluffier my patient is, the bigger my patient is, the harder it's going to be for me to feel that, right? Because there's a lot more adipose tissue that's interfering with me being able to feel that. If my mom has a little tiny basketball belly, it's going to be much easier for me to calculate those contractions. So again, there are things that impact your ability to pick up contractions. But this is where we place the toe over the top or fundus of the uterus. And then the fetal heart rate monitor, or better known as transducer, is put down at the bottom. If the baby's head down, then this, depending on which way the baby's laying, the spine should be here. Excuse me. The spine should be here, or the spine should be here. So we'll try either side and see where we can hear the baby's heartbeat best, and then we'll place it there. In that picture, they're using belts. At CIMC, they use these little things called tummy grips, and they look sort of like a tube top, but they fit over the belly. It's one big piece of fabric. It's very stretchy, and I think they're much more comfortable with those belts. So those are possible to use as well. Okay. And then those are external monitors. They sit, again, on the patient's abdomen. So I just mentioned something that affects the contractions and how well the contractions pick up. But also, the heartbeat and contractions are both sometimes not able to be picked up because of the patient's size, because of the patient's position, because of the patient's coughing, sneezing, vomiting, anything like that will affect both the heartbeat and the contraction pattern. So if we can't get them to pick up, we've got internal options that we can use. This is a picture of an internal scalp electrode. Okay. I've got a minor, I need 3 minutes. I have a minor emergency in my house. I've got to take care of. Excuse me just a minute. So let me take care of this. I'm so sorry. 3 minutes.
Take all the time we need. Y'all gonna go to a fashion show today? Fashion show? I'm in. Are you? It's like that from here? I would die. There's a 12:30. They're doing headshots from 11:30. No way, let's get it done. There's white. I wonder what kind of fashion for college.
Yeah.
It'd be nice though, thinking of something that you talk about what they are. What do you mean they're gonna give it back to them on the
That's what I'm going to do.
The pursuit of sloppiness. Fill in the blank one. I heard him talking about that. Yeah. That's a good one.
I don't watch the video yet. Oh, I have.
I'm going to pass around sheets that people can put down there, name their size.
Hey.
Five and a shirt or 10.
Yes.
You're a catcher.
No.
Huh?
I don't know how to use all that stuff.
It's only one easy. It's only one
Guys, I'm going to pass around a piece of paper. If you guys are wanting a t-shirt, like a class t-shirt, put your name and your size on it, and remember it's either $5 in a shirt or $10 altogether.
No, it's not a class t-shirt. These are just the t-shirts for the teddy bear fair.
Oh, okay.
Oh, I'm sorry.
Well,
Go ahead. Good timing.
I know Whitney's doing like class t-shirts or something like that.
okay.
Well,
But
they're
my
not
mom,
class t-shirts either. They're just like the fundraiser t-shirts to pay for pinning. Like they don't actually have like our class and graduation or date or anything on them.
Well, that's what I was
Okay.
just thinking about, like, for the teddy bear fair, because
Okay.
I assume that we wear it for other things, too, if we do.
Yeah,
Maybe,
it
I
won't
guess.
say teddy bear fair.
But
we don't have a teddy bear on it. That's what Miss.
I can be the guy, you're
Yeah.
right. Anyway, if you want one, just, if you're going to do the teddy bear fair, I guess, put your name on here.
So what all does it say?
It's just gonna say Green Valley Nursing and it's gonna have a teddy bear on it.
to be for any
Yeah,
of
we're
these.
gonna do that one.
That was on me.
Yeah.
I have a.
No, that was not. We didn't discuss them being for anything because they have nothing to do with SGA. What the fuck is that thing called? It's not SGA.
With toilet paper.
I'm just like, it's not SGA. No, it's not.
Sorry, service guys, I'm so sorry. So we were talking about
It is
ways to
confusing.
monitor the baby. We talked
I
about
stay
the external
confused.
monitor, which is always where we start. That's the non-invasive way of monitoring. That's what we start with. But if we have difficulty because of mom's size, because of mom's position, because maybe she's preterm, or she's moving a lot, whatever the reason, we can use internal monitors. This is a picture of an internal scalp electrode. You can see here it has a little corkscrew in the end, and it's got a teeny tiny sharp end, and it literally just screws into under the skin of the baby's head. It gives us a capillary access, and we have a heart rate that we don't lose, and it picks up all the time. We don't, have big blank spaces when there's nothing picking up. This is actually a good capillary reading. Now, this one, I chose this picture because I don't know how well you can see it, but in this case, the baby got an infection from the scalp electrode. It doesn't usually, you not even see the mark where the scalp electrode was. Right at birth, we kind of start to untangle the wire, and if you pull it, it just unscrews and screws right back out. And rarely do you see one with an infection, but it does happen. So we've talked a little bit about, I think in some clinical groups especially, about the risks of internal monitoring. One of the big risks is you're bringing bacteria ascending up into the cervix, into the uterus. So risk of infection is a big complication of internal monitoring. It has great benefits, but it also, you have to think about the negatives. The negatives are risk of infection, number one. Number two, in order to get these monitors in, the patient's water has to be broken, or you will break their water in placing them. Also, the patient has to be usually about 2 centimeters for you to be able to get your fingers in to put that scalp electrode on the head. You do it when you do an exam, and you just put the monitor, the little monitor with you, and you take your finger and just screw it on the top of the baby's head. So that's for the heartbeat, and then there's something I think on the next slide called an internal uterine pressure catheter that picks up contractions. How it works is it's this white tube right here. There's a transducer back here that it backs up to. It's a hollow tube about the diameter of a pencil, and it's filled with water. And so that is again placed with an exam. We just push it up inside the uterus, and it lays right beside the baby's head. A lot of times you'll see the baby will have a little indentation on their cheek from where it's been laying there, right beside of their head. What happens is when the uterus squeezes down during the contraction, it pushes that water back into that tube, and the water, the end of it goes back to a transducer, and it gives us a pressure reading in millimeters of mercury. So it tells us about the strength of the contraction in millimeters of mercury. How much pressure is being exerted by the uterus? So again, the water in the tube kind of backs up with the pressure, and gives us a pressure reading. So this can tell us about the intensity of the contraction during the contraction, but it also tells us about how much pressure is there in the uterus when there's no contraction as well. Because there is some pressure. It's not, in order for there to be zero pressure, the uterus would have to be ruptured. There is some pressure there during a contraction, or during the contraction, there's a lot of pressure. When there's no contraction, there's some pressure, but much less. So that's internal monitoring versus external monitoring. So the two big issues with internal monitoring that are negative: risk of infection, number one. Do I want my patient's water to be broken? If I can't get the patient's contractions to pick up and I'm worried about preterm labor and she's 28 weeks, is that a good reason to put these monitors in? No, because we've taken a 28-weeker and we've broken her water, and that would be contraindicated. So sometimes we have to work with what we've got. If we want to break the patient's water, great. That's a good time for internal monitoring if it's indicated. But if we don't want the patient's water to be broken, it's not, we would not do that just to put internal monitoring. Kind of like cutting off your nose to spite your face kind of thing, causing more problems that you're solving. And this is a picture of telemetry monitoring, which says you don't have to see agency, I'd give anything if they did. But with this monitoring, you can place the monitors on the patient, and then they can actually get up and move around. And think how many problems that we would solve by that. Remember all the positioning issues and telling you about putting the patient on Pitocin and have to be in bed and monitor continuously. This would solve all those issues. So I would give anything if they would get those at CAMC. They've got the capacity with the monitors that they have. What they don't have is the Wi-Fi capability in the ceiling or something. I was told it would cost a lot of money to go in and fix it, but I think it would be worth it. I really think it would even have the capacity to maybe lower our C-section rate if we could get our patients up and move around more often. Okay, so now we're going to talk about the actual monitor strip itself. This is a picture of a monitor strip, just like this one I showed you. How we read it is this. These wide blocks from here to here are 1 minute, and then these little square blocks are 10 seconds. 10, 20, 30, 40, 50, 60, 10, 20, 30, 40, 50, 60. So we've got 1 minute, 2 minutes, 3 minutes, 4 minutes. So we can count by the minute, or we can count by the 10-second block. Either way. On the top, we have the baby's heartbeat. On the bottom, we have contractions. So as you can see, the heartbeat here is running, oh gosh, it's 20 per 10. It's actually running low in this picture, like almost under 100, between 90 and 100. These are contractions. Contractions look like mountains. You know how I can tell this is an external monitor? Because of all this artifact right here. All this spiky stuff is irrelevant. You get a lot of spiky stuff with external monitoring. But you can see a definite pattern of contractions. They look like round mountains. They go up, they peak, they come back down. So the upper graph is baby's heartbeat. We can also graph mom's on there. If we put the little pulse ox on her finger, it'll graph mom's heartbeat on there as well as baby's. It's just a really light color so you can tell the difference. And the bottom is going to be contractions. Okay, so before we start talking about the baby's heartbeat, let's talk about how to assess uterine activity with these monitors, with these strips. All right. So there are 1, 2, 3, 4, 5 definitions here that you're going to need to know for monitoring contractions. First of all is frequency of contraction. Frequency means how often is one coming. So from the beginning of one to the beginning of the next is frequency. From the beginning of one to the beginning of the next. So when the patient calls us, my contractions are 5 minutes apart. What she's saying is every 5 minutes a contraction starts. It doesn't matter how long the contraction lasts, but how frequently do they start. So we measure from the beginning of one to the beginning of the other. Now, I think one of these strips in your textbook also says you can measure from the peak of one to the peak of the next, and you'll get the same result. But to me, when I'm looking at the bottom of the strip, it's much easier to monitor from the beginning to the beginning. That's frequency, beginning to beginning. So if I look at, so this is the 1 minute, the contraction starts here. 1, 2, 3, 4, 5, and then another one starts. So those two contractions are 5 minutes apart. Here's the beginning of the contraction. Here's the beginning of that graph of that minute. 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes. Those two contractions are 5 minutes apart. That's frequency. Everybody got that? Okay, let's move on to duration. Duration is what it sounds like. How long does it last? From the beginning of the contraction to the end of the contraction. How long does the contraction last? So how long does it look like this contraction lasts to you? 1 minute. Yeah, exactly. It lasts exactly 1 minute. As you can see, it starts here, it ends here. If it was about half of that, then we'd say 30 seconds. It's the whole minute there, so it lasts 1 minute. Strength or intensity of contraction. Intensity, unfortunately, cannot be measured with an external monitor. And it's for all those reasons I told you, because of your fluffy patient or your patient who's living all over the place or who's vomiting. It's just not accurate to monitor intensity with an external monitor. So if they have an external monitor, we say unable to document, or we give a subjective answer of our palpation. You can take your hand like this, put your fingertips over the fundus. When your patient says they're getting ready, they're starting to have a contraction, put your hand there and feel, and it should be, you can literally feel it get very hard underneath it and firm like a rock. And you can feel and look and see how long is it like that before it starts relaxing, when it's completely relaxed. And you can time contractions that way is just difficult. Kind of, once it starts relaxing, it's hard to tell when it actually stops. But that's called palpation of contraction. And that is a subjective descriptive term. We do use it sometimes, but again, it's very subjective. Years ago, when I first started working, we didn't use internal monitoring a lot. We reserved it for the worst cases. And we had to do, subjective palpation of contraction. So I was taught that if a contraction feels like your nose, it's mild. If it feels like your chin, it's moderate. If it feels like your forehead, that's strong. So I used to stand out in the hallway, with people on like this, trying to decide, is it mild, is it moderate, is it strong? But those were the three terms we would use: mild, moderate, and strong for contractions by a subjective means of palpation. So yes, it can be done, but yes, it's subjective. So and again, if it's tracing out on the monitor, again, it's still subjective. They may look like, if I have a little tiny girl with a basketball belly, her contractions are going to look like big mountains. Look at the patient with the same contractions that weighs 300 pounds, they're going to look like little blips. So again, an external monitor is not accurate. So strength and intensity can only be measured by an internal monitor. And I've got some slides I'll show you a little later that shows how to measure it. When we measure it, strength or intensity, we measure from the resting tone up, but I'll show you what that means in just a minute. So what does resting tone mean? Resting tone means what's the pressure there inside the uterus when there's no contraction at all. When all's well and she's calm, what's the pressure there? And it should be 20 millimeters of mercury or below. Resting tone should be 20 millimeters of mercury or below. If it's higher than that, we worry that the uterus is not relaxing like it should, like the contraction's not completely going away. And when would we see that happen? When they're on the 20 millimeters of mercury or below. NMHG or below. Resting tone. And then relaxation time is how much rest do they get between contractions. How much actual rest. So in this case, for a contraction, if our patient has a contraction that's 5 minutes apart, and that contraction lasts a minute, how much relaxation time does she have here? She has 1, 2, 3, 4 minutes of rest for the next contraction, right? She has a contraction that lasts a minute. She has 1, 2, 3, 4 minutes of rest or relaxation time, and then she has another contraction. The relaxation time is both for mom and baby. How much relaxation time do they get? A baby needs at least 1 minute of relaxation time to recover from contraction. So contractions should never be closer than every 2 minutes, especially if they're lasting a minute, because the minimum relaxation time is 1 minute. Your baby has to recoup. They're subject to hypoxia or hypoxemia during those contractions, right? So they got to rest. I use the example of this. So let's say you go to the pool, and Whitney and I are going to the pool, and I'll tell Whitney, I want you to go underwater, and I want you to hold your breath for 40 seconds. That's kind of a long time, I think. But anyway, hold your breath for 40 seconds. So she said, all right, okay, I can do that. She does it. She's fine, all's well. And then I said, okay, now 2 minutes later, I hold your breath for another 40 seconds. Okay, I can do that. I'm fine. All right, now do that every 3 minutes for the next 6 hours. How do you think you're going to feel if you go underwater and hold your breath 40 seconds out of every 3 minutes for the next 6 hours? Think you're going to feel kind of dizzy and lightheaded, and yeah, because over time that lack of oxygen is going to accumulate. So that's your fetus who's being subjected to lack of oxygen for a few seconds at a time. Maybe only 40 seconds for the peak of the worst part of the contraction. And it's no big deal for a little bit, but do it over and over and over and over for however many hours mom's in labor. And I wonder sometimes how our babies survive, how they don't really get hypoxic through all that. But that's the comparison. That's what do you think it'd feel like if you did that? Hold your breath for that long and then do it for hours on end. Okay, so let's look at this contraction pattern here. So this is an external monitor. You can tell. And it says TOCO up here. When it's IUPC, it'll intrauterine pressure catheter. It'll say IUPC instead of TOCO up in the lines right here. So you know which one you're dealing with. So that says TOCO, so it's an external monitor. So let's measure, let's do frequency. So everybody, let's calculate where we are from here to here with these contractions. So on this one, I'm about 10 seconds in when the contraction starts right here. So in order to go to a minute, I gotta go 10 seconds in over here. So I've got 1 minute, 2 minutes. Actually, it starts again about 10 seconds in. So about 1, 2, 3 minutes apart for those two contractions. The frequency is Q 3 minutes, right? Starts right here. So that's 1 minute, 2 minutes, 3 minutes apart, right? Frequency of there's 3 minutes. Let's do this one. Again, about 10 seconds in is where we're measuring from this minute mark. 1, 2, 10, 20, 30, so about 2.5 minutes on that. So on this piece of strip, the range of the contractions are 2.5 to 3 minutes apart. A lot of times you are going to get a range. They're not always going to be 3, 3, 3, or 2, 2. You're going to have 1.5 to 3, or 1.5 to 4, or something like that. And your normal contractions are never as regular as all that. Usually variation. So we'll document the range. So I've got 2.5 to 3 minutes apart for these three contractions. Everybody with me for frequency? Okay. So duration next. Duration, how long did it last? Let's see how long each one lasts. Here we've got 10, 20, 30, 40, about 50 seconds for that one. 10, 20, 30, 40, about 50 seconds for that one. Here we've got 10, 20, 30, 40, 50, about 60 seconds for that one. So I was going to document it, 50 to 60 seconds in duration. What's the intensity? Can I monitor intensity? I cannot determine intensity because this is an external monitor, so I have to say unable to assess, or if I'm palpating, I can describe my palpation, mild, moderate, or strong if I want, but I must document that's by palpation. Or just say unable to assess intensity. Okay? All right. Resting tone is something that should be 20 millimeters of mercury below. That's the rest, but that's another thing that can only truly be assessed by an internal monitor. So resting tone and intensity, anything that has millimeters of mercury behind it, has to be monitored internally to be accurate. So we're not going to put unable to assess resting tone as well. Now, relaxation time. How much rest is this baby getting between contractions? So here we've got 2 minutes for sure, right? So these two, there's no contraction. And then really it comes to the end of that minute and starts within 10 seconds of this minute. So it's got about 2 minutes and maybe 10 seconds there between those. And then here we've got 1 minute here, and then about 1 minute and 30 seconds rest right there. So that's relaxation time. Everybody with me? Because you probably will see this on the quiz. You will probably be asked, what's the intensity, what's the duration of this contraction, what's the frequency, and you'll be told whether it's an internal or external monitor, and then you'll have to determine that. Okay. Questions before we go on? Okay. All right. That's really all you have to know about contraction. Is the frequency, duration, intensity, resting time, relaxation. Those 5 things. We'll go back through them again. Also, if you want practice, go Google fetal heart rate monitoring, contraction monitoring. It'll give you all kinds of practice. I've got some scripts on here. I'm going to show you as well. But there's all kinds of things out there to help you, learn this. I mean, I'm teaching you the most basic part of it. There's so much more in depth to it than what we're actually learning today. But I'm just really skimming the surface with this. Just what I think you might see on NCLEX or HESI to be able to determine. Okay, so we're going to move on now to fetal heart rate patterns as opposed to contractions. So since labor is a stressor, we want to know how to measure fetal well-being. How's my baby doing? What we're looking at is we're measuring fetal well-being by looking at the response of the contraction. What response is the baby having to the contraction? How's the baby dealing with the stress of labor? Is the baby tolerating that going underwater every 40 seconds out every 3 minutes? How's the baby doing with that? If the baby's not doing well, we need to know because we need to know if the baby's not tolerating labor. So reassuring fetal heart rate patterns are, first of all, normal fetal heartbeat. Don't forget this. This is normal fetal heartbeat, 110 to 160. What's a normal adult heart rate? 60 to 100, right? So this is much higher. So from birth to an adulthood, the baby's heartbeat gradually drops. If you look at the rates off in childhood, you can see them dropping as far as the normal. When you get to an adult, it's 60 to 100, but for a fetus, it's 110 to 160. But there's so much more to it than just the rate. So you can have a normal fetal heart rate and have a baby that's really in trouble. So first is the rate, number one, and then with no periodic changes and moderate baseline variability. I'm going to explain what that means in just a minute. Now, in a preterm baby, in let's say a 28-weeker or 26-weeker, you might see a higher baseline fetal heart rate. It may run 160s and occasionally 170 just because of the immature central nervous system. But it doesn't typically go to 170s and 180s. Usually that's a sustained tachycardia above 170s is still worrisome. So again, if it's a preterm baby and it runs a little on the high side, we don't get too concerned. It's an immature central nervous system. Okay, fetal compromise. The goals of monitoring our baby intrapartum or during labor, is what that means, are to identify non-reassuring patterns indicative of fetal compromise. Non-reassuring fetal heart rate patterns are associated with fetal hypoxemia. If uncorrected, can progress to fetal hypoxia. What does that mean? What is fetal hypoxemia? What does that mean? Hypoxemia is what? Yes, anything that ends in emia is blood. So hypoxemia is low oxygen levels in the blood. So we're okay. I mean, I'm not saying we're okay with hypoxemia, but it's better than hypoxia. Because hypoxia means what? In the what? In the tissue. In the tissue. So low oxygen in the tissue is hypoxia. So you can start with hypoxemia. If it progresses and gets to fetal hypoxia, that leads to low oxygen in the tissue. And what does that lead to? Low oxygen in the tissue for long enough becomes what? The I word, ischemia, right? Tissue ischemia and then tissue death. Okay, so we've got 6 parts here. And really the first 4 or 5 are really, well, 2 through 5 are the biggies. We've already talked about number 1, which is the normal rate. Number 2, variability. I'm going to explain what that means in just a minute. Then we're going to talk about accelerations of the heartbeat, tachycardia, and then decelerations in that order. Okay. Assessing for normal rate. So how do we tell what the heart rate should be? So if you look at this monitor strip, when we are going to document fetal heart rate, we look at a 10-minute strip. You got that whole big strip for hours. How do you know what to document what the heart rate is? Well, you pick the most recent 10 minutes that have occurred. And you look at a 10-minute strip, and you look at what's the rate running all the way across. So let's assume I don't have any minutes it is. Let's assume it's 10 minutes. So if I look, what's the baseline, which means what is it when there's not all these up and down things, then I would say the heartbeat's running from the 130s to the 140s. We never document the heartbeat at 139. It's 132. We document a range, or 130s to 140s, or 130 to 147. So I would probably say 130s to 140s for a range here. And make sure that you look at just a 10-minute strip. Same thing if you're monitoring contractions. You would pick a 10-minute strip and you'd say, okay, in that 10-minute strip there were 4 contractions. They were every 1.5 to 4. They were mild by palpation. But the key is making sure you look at a 10-minute strip. All right, that's number 1, your rate and how to document your rate. Number 2, something very important is variability. So if I want to know your oxygenation and how well you're oxygenated, what can I do? Well, look at all the options I have. What do I have to? If I'm worried about Anthony's oxygenation, what do? I check his stats. That's one thing I can do, right? I can ask him, how do you feel? Are you short of breath? Let me see your nail beds. Are they pink? All those options. I can see if he's pink. I can do his stats. I can ask him how he feels. I can ask him if he feels tired. I've got all those things available to me, none of which I have with the fetus, right? So I can't assess a fetus's oxygenation by any of those methods. I really have one thing, and it's variability. Variability is the difference in the heartbeat from one beat to the next beat to the next beat. So you, again, back to Anthony, if I said to Anthony, check your heart rate right now, and he says, oh, it's 75. I say, run down to your car as fast as you can and run back. Well, he's younger than me, so he's much better than me, but if it was me running back, mine would be about 150 when I get back up, probably. So our heartbeats increase dramatically based on activity, right? And they vary based on activity. On the other hand, if I just say walk slowly out in the hallway, his heartbeat might go from 75 to 85. And then it comes back down. Why does it do that? He's up walking or he's running, so what his body requires more perfusion to more tissue, so his heart beats faster. Does that make sense? It's the same thing with the fetus. The heart speeds up when the baby moves. The heart rate slows down when the baby's at rest or when the baby's sleeping. If Anthony's sleeping tonight, his heart rate's probably, if normal 75, his heart rate may be down in the 60s tonight while he's sleeping. And then in the morning when he gets up, it may pop back up in the 70s. So the variability is what happens when a healthy person moves. And it's the body's response to a demand for more oxygen. So if my baby is healthy and doing well, my baby will move. And if my baby's moving, the heart rate will go up accordingly. So that's really what we're looking at, because I can't check this out. I can't see if my baby's pink. I can't look at the nail beds. I can't do any of that. But I do know that if my baby's not healthy, they won't move. Babies aren't dumb. They know that if they're not healthy and there's not enough oxygen there, they know not to move. If Anthony has COPD, on the other hand, and I say, go run to your car, he would say, no, I can't do that. I'm sick, and I can't get enough oxygen, and I can't run to my car. So he moves slow, he sits still, he gets himself in a position where he can get his breath, and he doesn't move a lot. Same thing with a fetus. This is how, when they're well oxygenated, they move. Now, for a baby, their movement is stretching and rolling and all that stuff. They're limited, obviously, to their environment. But they do still move, and it increases their heart rate dramatically. If they sleep, their heartbeat may level off and may even slow down a little bit. Still within normal rate, but it may slow down. So variability is the difference in the heartbeat from one beat to the next to the next. So it just stands to reason that if my baby's doing well, the heart rate will vary a lot, and that would be a good thing, right? So variability, we look and see what the baseline heartbeat is first of all, and if it varies hardly at all, absent 0 to 2. If it's running 150, 151, 152, 150, 151, 151, 150, 151, 152, that baby has no variability. Minimal no variability. 0 to 2 beats, variability is absent. Minimal is decreased, and that is when it changes a little bit, but not enough. 6 to 25 beats is what we call normal, and then marked is greater than 25 beats, which is also abnormal. Unclear significance, we don't really know what that means. So let's talk about why there might be absent or no variability. What could cause that? First of all, is my baby sleeping. Babies all sleep. They have sleep cycles of up to 40 minutes. Usually it's 30, in some cases it can be up to 40 minutes. So if I see poor variability in my baby, I know it could be the baby sleeping, so sometimes I have to wake the baby out and see if the baby wakes up, or try to wake the baby up and see if we can get the variability to increase. I'm going to show you some strips in a minute to show you what this looks like. Sleep cycle for my baby. Maternal sedation. If I give my mom morphine or something that is sedating, am I going to sedate my baby too? Absolutely. So essentially my baby is in an induced state of sleep in this case, induced by mom's sedation. Maternal hypoglycemia. For some reason, if my mom hasn't eaten and her blood sugar is low, the baby won't move. When we bring our patients in for outpatient testing, first thing we ask them is, have you eaten breakfast today? Because we know if they haven't, we're going to get a bad test. Because the baby won't move if the baby's blood sugar is low. Because if mom's blood sugar is low, baby's is low too. So sometimes we'll send them to the cafeteria and say, go drink something with some sugar in it. Get your baby moving this morning. So maternal hypoglycemia. Then the last is fetal hypoxemia or hypoxia. So it could be something bad. One of the worst things we see is poor variability in a baby. It's a sign of a baby that's not getting enough oxygen. Because the baby knows that if he moves, he can't get enough oxygen, so he just refuses to move. But we have to rule out all the other stuff first. So sometimes we can't get an immediate handle on whether there's a problem or not. Is my baby sleeping, or is it hypoxia or hypoxemia? Sometimes we have to kind of wait and see. Okay, so let's look at some strips and see what this looks like. We look at the monitor strip. This is what we call no variability. You may hear them in labor room, we call it flatline. I mean, to you all, flatline is somebody who has asystole and asystole. That's not what this is here. We've got a clear heartbeat, and it's running anywhere from 160 to 170 as far as, but if from one beat to the next, you see it barely changes. It's, 170, 170, 169, 169, 168, 167, 168, 166, 166, 160. See what I'm saying? It's very slowly changing a little bit, but it's very flat. What we would rather see, the graph of the heartbeat, this is what we call minimal. This is a little harder to see, but you can see a little bit of squiggly here. You can see a little bit of squiggly. This is about 3 to 5 beats of change from beat to beat to beat. And then this is what we call moderate. So what you might think of as BFib, in the cardiac monitoring world, we call this a happy baby. Moderate variability, anywhere from 6 to 25 beats between each from beat to beat to beat. It's changing of the heartbeat. In a baby, we don't like to see the heartbeat stay the same. We like for it to vary. That means the baby's reacting to its environment. He's moving, and he's moving because he can and because he has good oxygenation. If he doesn't have good oxygenation, he just won't move. This is marked variability. That's actually sort of more like BFib. Marked is greater than 25 beats, and it is considered an abnormal finding with unclear significance. Now, let's go back here. What I'm going to ask from you, because it's really hard to determine from the monitor strip at your all's level what's good variability and what's poor variability. So what I'm going to do is let's do this for practice. Okay. Here's the baby's heart rate from beat to beat to beat. If we pulled it off the monitor strip, it would say, okay, here's a bunch of beats. What's the difference between 130 and 137? 7, right? Yeah. What's the difference between 137 and 144? 7. 144 to 130? The difference between them is 14. 130 to 143, the difference is 13. 143 to 129, it is 14, right? 14 beats, right? So my lowest number is 7. My highest number is 14. So what's the variability? Moderate. Very good. Let's do another one. So instead of you all have to try to look at a fetal monitor and determine it, I'm going to give you a list of beats like this and ask you to tell me what the variability is that way. Okay, here we have a difference of 1, 1, 0, 1. So we've got 0, we've got a 1. So what's the variability here? Good, good. All you're doing is looking at a group of beats. What's the difference between one beat to the next? Beat to beat variability. What's the difference? Look at your lowest number, look at your highest number. That's your variability. We'll do one more. You will see this again. Like I said, it takes nurses months and sometimes a year to be able to determine variability by looking at a strip. So I think this is good. Yeah. Okay. 150 to 155. 155 to 151. 151 to 154. 154 to 158. 158 to 150. Okay. Now we got something interesting. Our low number is 3. Our high number is 8. So what's the variability now? It's really, if you look at all your beats, everything except 1 is in the minimal range. For testing purposes, I'll try my best to keep it in the ranges so I don't confuse you. But when you have a bunch of beats and only one of them goes outside, you go with whatever the majority of the beats are in. So I would call this minimal. You have one beat in the moderate range, but all the rest of them are clearly minimal. So if you have one like that that has an overlap, look and see where's the majority of your beats fall, and then categorize it that way. But like I said, I'll try my best to keep it within the ranges so you don't run into confusion. But that's how you determine variability. So we just transfer this to being able to read the strips and seeing what the beat to beat variability is on the strip. That's really all you're doing. Instead of looking at the strip, you're looking at a group of beats to determine the same thing. So I will probably ask you to do this. I will give you a set of beats and ask you to determine that. Make sure that you remember what are causes of poor variability. You know, if we can excuse it, if we can say, well, is the baby sleeping, or did my mom just get morphine for some reason, or some kind of sedation, then by all means, we know that might be the cause of it. What if my mom is on methadone because she's in a withdrawal program during pregnancy? I may have a sleepy baby all the time, right? What do I do about that? That's a really tough one. Because we know that the drug may be causing the baby to be sleepy, so it's really hard to assess variability if your mom is sedated. So sometimes we have great difficulty assessing it, and we just have to kind of live with that. It's not very often that we have somebody that's on something all the time. So what we like to see is when they're off of it, is the baby recovering with better variability. If the baby's sleeping, we can wait 30, 45 minutes, or we can try to wake the baby up, kind of move around the mom's belly a little bit. If you do a cervical exam, you can if she's dilated at all, you can actually kind of scratch the top of the baby's head off. That'll wake the baby up, so we can try to wake the baby up if we can, or we just wait. But determining variability can take a little bit of time. It's not something we can do immediately because we might be blaming it on sleep cycle or maternal sedation. If it's hypoglycemia, we can feed our patient or change their IV to something with some D5 in it. But if we see it over time, it becomes alarming. We're concerned about fetal hypoxia. Questions about variability? Everybody understand it? Why, you understand why the heartbeat varies? It's nothing new. Your heartbeat does the same thing. We just don't monitor you that way to assess your oxygenation because we have so many better ways to do it. This is all we have for a fetus. It's the best we can do. And it is pretty indicative. But again, there's so many things that interfere with it, in sleep cycle, sedation, hypoglycemia, all that sometimes it's hard to see through all the haze to see what's really going on. So we look at that and some other things too that we're going to talk about next. Okay, variability. That's absent, minimal, moderate, and marked. And I rarely, if ever, have seen marked. Almost never have I seen it. All right, number 3, acceleration. Acceleration makes us happy, happy, happy. We're always happy with accelerations of the heartbeat. Because again, if my baby's active, what does his heartbeat do? It speeds up, it accelerates, right? So anytime the baby's heartbeat's accelerating, that is a good thing because my baby is active. It's telling me that my baby's responding to his need for oxygen by increasing his heart rate. So he's moving, he's responding to his oxygenation needs. A fetus cannot and will not be active without adequate oxygenation. They'll just quit moving. One of the first things they do when they're not doing well is quit moving. That's why you'll learn in the next chapter, start the 3rd trimester, we have our patients do kick counts. Monitor the fetal movement, have mom monitor it at home to make sure the baby's moving okay, because that's what stops first. When your baby's not doing well, they stop moving. So it's always reassuring, means that there's fetal activity going on. Fetus cannot be active without adequate oxygenation. Even in the presence of some decelerations, if there's accelerations too, which I've seen, it means the fetus is usually doing okay. So if I see accelerations and decelerations, both, usually I'm pretty much like, okay, we might have something going on here, but this baby's still got good reserve, still doing okay, not worn out yet. It's got, some reserve left in it. And that's a picture of accelerations of the heartbeat. In the next chapter, you're going to learn, like, what are the definitions, how high does it have to be to classify the deceleration, because there are parameters. For a term baby, it has to go up above the baseline by 15 beats and last 15 seconds. This one certainly lasts 10, 20, almost 30 seconds of that acceleration lasted. Here it lasted maybe 20 seconds. But you can see acceleration, 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 acceleration. The rest of it is the heartbeat. So that is a happy camper. Happy baby that has acceleration and heartbeat. They always make us happy all the time. There's never a case where acceleration is going to make us unhappy. Okay. Next, tachycardia. So obviously 110 to 160 are numbers. 160 or above for a duration of at least 10 minutes or longer is the definition of fetal tachycardia. So it might jump up for 2 minutes and come back down. That doesn't really bother us. But if it's what we call sustained tachycardia, it lasts at least 10 minutes or longer, then that is called fetal tachycardia. Immature, as I said, central nervous system may cause a high baseline, but not sustained tachycardia. Even if it's a preemie, it may pop up to 170 here and there. It may run a high baseline of 150, 160, but it's not going to be 170, 180 that we see when we see sustained tachycardia. Why would the baby have tachycardia? One of the biggest things, or the most common thing, is maternal fever. Because if mom has a fever, what does her heartbeat do? If you have a fever, what happens to your heart rate? Your heart rate goes up too, right? So I can't check my baby's temperature regularly. I can check my mom's temperature. So if I see fetal tachycardia, usually the first thing I do is check my mom's temp. That's the simplest thing. And if my mom has a temp, I guarantee you my baby has a temp too. I just can't check it. So the most common cause of maternal tachycardia, the most common cause of fetal tachycardia is maternal fever. Something else that can cause it, maternal stimulant use. If my mom, a big hit of methamphetamine, what's that likely to do to her heart rate? Right. Increase, right? So if her heart rate increases, is baby's heart rate going to increase too? Yes, absolutely. So maternal stimulant use, maternal fever, which is the most common, and then fetal hypoxia, a fetus that's really tired and just doesn't have any more reserve. You will see tachycardia usually accompanied by decelerations as well, which we'll talk about next. Be especially concerned with fetal tachycardia accompanied by poor variability. So if you have a heartbeat running in the 180s and the variability is absent or minimal, that's like a double whammy. It's one of the worst things you can see. It basically means your fetus just had it. They can't take anymore. Maybe those contractions are coming too close and they're just not getting enough rest and they're just worn down. And that is a really bad sign, a combination of fetal tachycardia and poor variability at the same time. And here's a picture of fetal tachycardia with poor variability. You can see how it looks almost like a flat line. It's running like 170 to 173 maybe, 174 at one spot maybe. And it's clearly above 160 and looks like it's probably sustained. If you look over a period of minutes, it's staying right up there. Okay. Now, we just got about 30 minutes left. Y'all need a little breather before we finish the last. Take a couple minutes and maybe just take 2 or 3 minutes. And if you need to go to the bathroom or get a drink, well, we'll start back in just a couple of 3 minutes. I want you to catch your breath before we finish this last part.
Yeah, but it's actually
I'm glad that you all
you know what I'm experiencing.
see the best. I think we worked from 7 to 11.